Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Intensive Chemotherapy and Immunotherapy in Patients with Newly Diagnosed Primary CNS Lymphoma, CALGB 50202, by James Rubenstein et al. My name is Tracy Batchelor, and I am the Executive Director of the Stephen E. and Catherine Pappas Center for Neuro-Oncology at the Massachusetts General Hospital Cancer Center in Boston, Massachusetts. My oncologic specialty is neuro-oncology. Primary CNS lymphoma is an uncommon type of extranodal non-Hodgkin lymphoma confined to the brain, leptomeninges, or eyes. Although more than 90% of primary CNS lymphoma cases are classified histologically as diffuse large B-cell lymphoma, the survival of patients with primary CNS lymphoma remains inferior to that observed in patients with diffuse large B-cell lymphoma occurring in other body sites. This may be due to the unique biological properties of primary CNS lymphoma, the role of the blood-brain barrier in limiting drug delivery to the tumor, and/or the lack of effective therapeutics. Consensus is lacking regarding the optimal induction and consolidative treatments for primary CNS lymphoma. Although methotrexate is widely accepted as the foundation of induction chemotherapy for primary CNS lymphoma, the optimal dose and schedule for this drug have not been defined. At the dose of 8 grams per meter squared, cytotoxic concentrations of methotrexate are achieved in the cerebrospinal fluid, obviating the need for intrathecal chemotherapy. Whole brain radiation therapy, while effective in achieving complete responses in the brain in most patients with primary CNS lymphoma, might not improve survival over chemotherapy alone, does not adequately treat the entire craniospinal axis, and is associated with delayed neurotoxicity in most patients. The latter complication of whole brain radiation therapy may adversely impact cognition, functional status, and quality of life in patients otherwise successfully treated for primary CNS lymphoma. While reduced doses of whole brain radiation therapy might be associated with a lower incidence and severity of neurotoxicity in humans, this remains unproven, and experimental studies have demonstrated that even single fractions of whole brain radiation therapy result in ablation of hippocampal neurogenesis and consequent neurotoxicity. The latter observation raises the question as to whether any dose of whole brain radiation therapy is safe, an important issue for a disease with survival measured in years. Despite these limitations, whole brain radiation therapy has been viewed historically as an integral component of either induction or consolidative therapy for primary CNS lymphoma. This view has been challenged in recent years, as studies of chemotherapy alone suggest a diminished risk of neurotoxicity and promising efficacy in primary CNS lymphoma patients. In a long-term follow-up study of primary CNS lymphoma patients treated with chemotherapy alone and monitored with serial neuropsychological tests, cognitive function and quality of life were maintained. In the article that accompanies this podcast, Rubenstein and colleagues report results from a cooperative group, multi-center, Phase 2 clinical trial, CALGB 50202, of chemotherapy without whole brain radiation therapy in 44 patients with newly diagnosed primary CNS lymphoma. Each of the drugs selected for the methotrexate, temozolomide, and rituximab induction regimen, referred to as MTR in this podcast, had demonstrated safety and efficacy as a single agent in prior clinical studies in either newly diagnosed or relapsed primary CNS lymphoma patients. Etoposide and cytarabine, referred to as EA in this podcast, had previously been combined as effective salvage therapy in a study of patients with relapsed primary CNS lymphoma. Rubenstein and colleagues demonstrated that MTR induction and EA consolidation are feasible and safe in the multi-center setting, with expected reversible myelotoxicity associated mainly with consolidative EA therapy. There was one treatment-related death due to sepsis in a subject managed as an outpatient during EA consolidation, prompting the authors to wisely advise that both the induction and consolidative components of this chemotherapy regimen should be administered on an inpatient basis with appropriate supportive care. 2/3 of the primary CNS lymphoma patients enrolled in this trial achieved a complete response to induction MTR, the primary endpoint of the study. This complete response proportion is comparable or superior to that reported in other prospective multi-center trials of induction chemotherapy for primary CNS lymphoma. The 44 patients enrolled in CALGB 50202 had a median progression-free survival of 4 years, and 59% of these patients were progression-free at 2 years. These are impressive achievements, comparable or superior to results obtained in other prospective multi-center trials with regimens that included whole brain radiation therapy as consolidative therapy. Median overall survival for the CALGB 50202 study had not been reached at the time of publication, with a 4-year overall survival probability estimated at 65%. Based on these outcomes, it appears that omission of whole brain radiation therapy from the initial treatment plan for primary CNS lymphoma did not compromise progression-free or overall survival in the patients enrolled into this clinical trial. There were no cases of severe neurotoxicity in the patients enrolled in CALGB 50202. However, there was no prospective serial assessment of neurocognitive function in this study, a limitation common to many other primary CNS lymphoma clinical trials. While other studies strongly suggest that treatment regimens for primary CNS lymphoma that include whole brain radiation therapy are associated with a higher incidence of symptomatic neurotoxicity than regimens that do not include whole brain radiation therapy, it is equally important to prospectively assess whether and to what extent chemotherapy might adversely impact neurocognitive function in this population. A battery and schedule for such assessment has been developed and is incorporated into several ongoing prospective multi-center clinical trials for primary CNS lymphoma patients. An important observation by the authors in CALGB 50202 was that a delay in starting induction chemotherapy had a detrimental impact on tumor response and outcomes in patients enrolled in this study. More than half of the patients with a greater than 30-day delay in treatment initiation died from their lymphoma, compared to less than 30% of patients who started treatment within 30 days. This observation highlights the importance of early diagnosis and prompt initiation of chemotherapy in patients diagnosed with primary CNS lymphoma. The diagnosis of primary CNS lymphoma is typically achieved after stereotactic brain biopsy, with sparse tumor tissue remaining for biological studies. This has compromised our understanding of this unique subtype of non-Hodgkin lymphoma. There are no established imaging or biomarkers that can identify treatment-resistant versus sensitive primary CNS lymphoma subpopulations at the time of diagnosis. It is encouraging that 59% of subjects enrolled in the multi-center CALGB 50202 trial had sufficient tissue collected and provided for centralized immunohistochemical analysis. Based on preliminary data generated from single institutions or retrospective studies, the authors examined the prognostic utility of 2 biomarkers, BCL6 and MYC, in a correlative biospecimen study as part of CALGB 50202. In these studies, MYC expression did not correlate with outcome. However, BCL6 expression in greater than 60% of tumor cell nuclei was associated with inferior progression-free, event-free, and overall survival. While this suggests that BCL6 expression might be a marker of a more resistant subtype of primary CNS lymphoma, these results should be interpreted with caution, as it was based on tumor specimens from 26 subjects, and prior reports of BCL6 expression in primary CNS lymphoma have yielded conflicting results with respect to outcomes. Nevertheless, the authors demonstrated the feasibility and potential importance of incorporating biospecimen studies into prospective clinical trials in primary CNS lymphoma. The results of CALGB 50202, reported by Rubenstein and colleagues in this issue, demonstrate the feasibility, safety, and efficacy of the MTR induction and EA consolidation regimens in newly diagnosed primary CNS lymphoma patients. Omission of consolidative whole brain radiation therapy did not compromise progression-free survival and eliminated the risk of radiation-induced neurotoxicity. While further study is required before these results can be generalized to the entire primary CNS lymphoma population, especially elderly patients, the authors are to be commended for their effort, which has raised new questions and set the stage for subsequent clinical trials to build upon the success of CALGB 50202. Since less than one-fifth of the grade 4 cytopenias observed in this study occurred after MTR, an important question is whether this induction regimen can be intensified to increase the proportion of CR patients prior to consolidation. Another question is whether the results achieved with EA consolidation could be improved by substitution of high-dose chemotherapy followed by autologous stem cell transplantation, a consolidative strategy that has achieved encouraging results in a multi-center Phase 2 study. The latter question will be addressed in CALGB 51101, an ongoing intergroup randomized trial in which all primary CNS lymphoma patients are treated with induction MTR followed by consolidated EA versus high-dose chemotherapy and autologous stem cell transplantation. Following in the footsteps of Rubenstein and colleagues, CALGB 51101 includes correlative biospecimen, imaging, neurocognitive, and quality of life studies in an effort to better understand patient outcomes, including the short-term and long-term consequences of these treatments on the growing proportion of long-term survivors with primary CNS lymphoma. This concludes the JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.